Rheumatoid arthritis. Okay. We've already said a lot of this, but the other thing about that it starts as inflammatory, it also is a systemic disease. Did you catch that in the video? It is a systemic disease. It is not just in the joints. That's just where a lot of the manifestations can be. It is a chronic autoimmune disorder, and it can cause connective tissue inflammation, primarily in the synovial joints. So, and I need to get that light back on back there because it is really dark in here to try to do notes and everything, especially when y'all are handicapped. So, is that okay? I think this is a little easier to see. Then, they don't know what causes this to happen. They know what goes on, but they don't know what really elicits it. It could be, they think, likely genetic, environmental, hormonal, reproductive. There's all these things that come together in certain people to cause that predisposition. So, anyway, it is autoimmune disease, and we know about what autoimmune disease is really, about the hypersensitivity. It's a type 3 hypersensitivity where you have those immune complexes that actually cause that inflammation in the joints and in other organs and all too. It is more common in women between 40 and 60 years old, and people that have had a family history of it, and smokers are more susceptible. But it can happen at any age. You can have, obviously, it can happen to children. That's one reason I picked that video. But the incidence has decreased in the last 40 years. They don't really know why, but it is much less common than the osteo. And I'll put some page numbers for you for Iggy. But it can have minimal joint damage or joint problems, joint symptoms, or multiple inflamed joints, and you can have a lot of deformity with that. And it can decrease life expectancy, but it certainly can cause disability, like that little girl saying that she wished she'd done some handsprings before she knew what kind of progression that this was going to undergo, and that she's going to have knees replaced already, which is what, 16, 17, isn't that what she was? But anyway, it is a disease of remissions and exacerbations. So, you know what remission means, right? It can stop having symptoms sometimes, and then other times it can flare up. They call it a flare up. Exacerbation really means a flare up. And it's sort of like y'all have heard exacerbation of COPD a bunch. You get that in the hospital a whole lot, at least on my floor, and that we're on the surgical floor, but we have a lot of exacerbated COPD patients too. So that just means it's getting worse. It's a flare up, and so you have to treat it more aggressively at that particular point. So, and that is something that is in common with lupus. Just so you know, we'll be on the slides for that as well. So, okay. All right, and you sort of saw that picture on the video, but they in the caption there, the PANAS is like a development of granulation tissue, sort of like you would have in a surgical wound or something like that. But then it kind of heals into a scar, and so the synovial membranes are not lubricating like they're supposed to, and then those autoimmune complexes cause inflammation in that area to just continue. So our normal antibodies become autoantibodies, and we don't know why. This is one of those just weird things that we need to get figured out about our bodies. And leukocytes get attracted, our white blood cells get attracted to that, and then we've got natural killer cells and all that kind of thing that are coming in there and destroying and causing tissue damage. But the PANAS is really just like when it sort of becomes like the granulation tissue, and then it's scarred, and then that causes immobility, and that's probably why little girls haven't had disease. Okay, our symptoms. I underline the fatigue and malaise. Sometimes that's the first sign that that's what it is, and it's one of those kind of afterthoughts though. The patient when they find out that they start having the joint problems, they can kind of go back up and instead of were you really tired before this, or did you just kind of feel like you just weren't right but you didn't know what was bothering you? That's kind of what malaise is. You can go back in the history and see before the joint damage showed up and say, you know, I was really, really tired. And so that may be the very first manifestation and one of the most serious ones, actually, as things go along. So, your book didn't, this one was from the concept book from last year, but they distinguished the osteo and the RA, that morning stiffness usually lasts more than an hour. I think it said 45 minutes or something in Beaver. But it's going to be longer morning stiffness that you can have with osteo. But the more that you get up and move with osteo, the better you get. But not necessarily with RA. You may, it lasts at least an hour, and then it can be significant and disabling. It may not go away at all during the day. But osteo, it usually, once people get up and move, and they may not be 100% mobile, but they do have more mobility than they did when they first woke up in the morning because of the just being still and everything. Once they start moving, they do better than they would do when they first got up from being immobile. If they've been sitting in a chair for a long time and then get up, it's going to be the same sort of thing. It'll take them a while to get adjusted, but it's a longer kind of situation with the RA. So, let's see. One of the things too, talking about the fatigue, you have to realize too, you're going to have pain. That's why I had that pain song. You know, we haven't got time for the pain. You've got the pain, and then you've got joint damage and stiffness and all this sort of thing. But to begin with, if you had a fatigue and malaise even before the joint situation, what would be a nursing diagnosis if you knew ahead of time? Well, even if you don't know what caused it, what fatigue and malaise cause as far as your yeah, well, maybe not. You may just not have as much activity tolerance. Maybe, yeah. Is that what you mean, like activity tolerance? And then, but that's really before you know that the joints are damaged. You might have this fatigue. So what else? Like if you're a busy mother and you've got to run your kids all over the place, but you work full time too, and all this kind of stuff, what's going to be altered? Yeah, like role performance or home maintenance, all that kind of stuff. So think about that as maybe the first nursing diagnosis that pops up, even though you don't even know what's causing it. But anyway, the widespread muscle aches, weakness, all those kinds of things can be the presentations. And then eventually the joint pain will come. And if the joint's not used for a while, it can become warm and tender and stiff. And then the line becomes inflamed and it gives off more fluid. What's fluid got to do with this? What did we say? What kind of joints?
Synovial.
The synovial. And the synovial membrane produces some liquid to lubricate. It's like oil in the the parts of a machine or something like that. And so so it makes too much though, and it causes the swelling and the puffiness in the joint. But one of the things too, difference with osteo and RA is in osteo you can't have one side get inflamed or to get damaged before the other one does. It doesn't have to be symmetrical with osteo. It can be, of course, but with RA it's pretty much 100% symmetrical. It may not be exactly the same degree depending on how much wear and tear you've had. You can have RA and osteo at the same time too. Now that pity the poor people that have to deal with that, but you can have both. So if you've been like a quarterback on a football team and you've used your shoulder over and over and over and over and over, you may have osteo along with the RA if that hits you too. But of course, it's more likely to be women than men. But I guess a woman could be a quarterback too, coach, or basketball player, whatever. So anyway, remission is likely within the first year. And the other thing is unusual is that some people have remissions during pregnancy. The hormones that are coursing through the mother can decrease the inflammation and they can have a remission during that time. But then they usually have a relapse after the birth. So yeah, getting pregnant can be a great thing, but after the 9 months, there's have to be paid after that. So, but that's something that people need to be counseled about. That yeah, that if you really want a child, that you're probably going to feel really good while you're pregnant, but then afterwards you really may not. So you may need to make sure that you've got some help with your child care, because you may not be able to if you have a relapse. So, all right. And this is something that would be nice for y'all to know. Most chronic diseases cause mild to moderate anemia. I think that was in I think that's number I knew that. And I knew that, and you can say anemia of chronic disease sometimes. When you know somebody has, when you see their history when you're in clinical, you look at this big long history of all these diseases that this person has suffered or is still suffering from chronically. If you can't find any other reason like blood loss or failure to produce blood cells and things like that, if you can't find any of those types of reasons that would be very obvious, then it may be anemia of chronic disease. So that's definitely something that RA patients can have. So the bone marrow is affected with this inflammation. You can have burning eyes and itchiness and discharge. And I think I read, well, Taylor was talking about this with the Sjogren's syndrome, and that's in that chapter. And I did include that in the pages for y'all to read, didn't I? It's in the chapter anyway, and it can be, sometimes people can have RA and Sjogren's at the same time, and it really drives out the mucous membranes. We talked about that in somebody in your family, right? Your mom has had that, so, but she doesn't have RA, right?
She has all that.
So it may be off there, so anyway, I hope to put this on, but anyway, those can have some crossover anyway. You can have low-grade fever, especially with exacerbations and when inflammation is really high. Lung inflammation, pleurisy, or effusions, like the pleuritic membrane gets irritated, and every time you breathe, it kind of scrapes. It's like the surfactant, you know the word? The surfactant that's between the lung and the lung line and the pleura. If the surfactant gets sticky and it's not lubricating well, just like the joints aren't lubricating properly, and then that can cause a lot of pain. You can get that with pneumonia and other lung conditions as well. Pleural effusions can develop where it produces too much fluid, and then that keeps the lungs from being able to fill back with air as well. And you can have nodules under the skin in areas that are subject to pressure, and it's usually in the more severe stages of the disease, and they can open up and get infected. So that's something to teach the patients to assess on their own, and then you want to do that when they're coming to a doctor's office visit or a hospital or whatever. I mean, there can be some numbness and tingling that can affect the nerves in the areas that are affected as well. And anemia is resistant to iron therapy. It is not an iron deficiency anemia. It is just the body's having the bone marrow just not able to use the components that it does have to make as many blood cells as you need. And so I might see the patient be pale, redness, inflammation, swollen glands, and joint destruction usually doesn't start occurring within about 1 to 2 years after the diagnosis. And you can have muscle atrophy around the affected joints with it, and the muscles aren't able to be used as much because your joints aren't working well. They're not working well together. And I think there's a picture in your book that shows how the muscles are connected to the joints, and all you see that in anatomy physiology. You go down to the library and see what's that skeleton called? Dexter? It's Dexter, and then but you can kind of see where the connection points are with the skeleton, and you can look at that anatomy thing on stat rep that if you wanted to. But I think there's a picture in the book that might suffice. If you get one of the real serious problems is vasculitis, which is inflammation of what?
Blood vessels.
Yeah, vascular system, blood vessels, exactly. And you can have increased C-reactive protein. What is C-reactive protein? CRP. Have y'all had to look that up before? Chris, inflammation, right. And what about the acid rate? What is the ESR, erythrocyte sedimentation rate, signify?
Inflammation.
It's inflammation too, isn't it? Yeah. But when you have a lot of C-reactive protein in your blood, people who have C-reactive protein in the blood have more incidence of cardiovascular problems. And we don't know if the C-reactive protein is the cause of it or if that's just a sign that you have it. But it's not a good thing to have a lot of C-reactive protein in your blood. That can be a real bad cardiovascular sign. I read that in some health newsletter or something years ago, and it was talking about B complex vitamins can help reduce CRP levels in your blood. So I started taking B complex. I don't know if that really helps or not, because I certainly eat well, but I still do that just because I'm scared of having CRP, and I know heart disease has killed a lot of the women in my dad's family anyway. So he had a lot of sisters, and several of them died from heart disease. But you can have low levels of HDL, the good cholesterol, and the high levels of the bad, the LDL, and then high triglycerides, high blood pressure, high homocysteine levels. On all of that decreases coronary heart disease, and that's why we're talking about systemic disease. You don't really think about arthritis, because that arthra means joints, right? But it's not just arthritis. That's just what they noticed first about it, and then you start seeing that it really is systemic. And you can have pericarditis. The outer lining of the heart can swell, sort of like irritation in the lining of the lung. And then you can have congestive heart failure, which then have swelling in your ankles and everything, the dependent edema we were talking about before. And there are a lot of medications that treat RA that can actually kind of increase and have an additive effect on the damage to the disease itself. So this is not a fun thing at all. I know y'all do that. That is just so sad to do it. And I'm not going to make you memorize that all of, exactly which joint, I was like, PIP joint, PIP, okay, and I have to remember that. It's proximal interphalangeal joint. I think I have that on the notes page somewhere. PIP, I was like, okay, what's that stand for? And then you got the metacarpals and MCP, metacarpal phalangeal joint, that's what that is. So, but you can see where it is, and you can see how the deviation goes away from the thumb. You can see it's doing kind of an ulnar deviation, they're saying, because if you're going toward the radius, you'll be doing sort of like internal rotation, but if you're going toward the ulna, it's sort of an external rotation with all the other deformities along with it. But you see it is going outward, so that's the ulnar deviation. And you can have your little susceptible carpal tunnel with all that going on too. We've had some patients in the hospital, not since this rotation, not with y'all's class, but people were just so gnarled up with their hands and feet that you wonder how they can really do anything. I guess somebody has to do everything for them, because how could you manage? Are y'all getting frustrated with your tape hands? I know that's not your dominant one, but still, that's just so sad to see somebody like that. And you can see the visible swelling, like we saw with the little girl, unstable joints, ankles and feet can be painful and deformed. And that subluxation and hallux valgus, I just put that there. You don't have to memorize those names, but know that when you see subluxation, you know that it's not normal in hallux. Hallux valgus is not either. The great toe goes toward the other toes. Again, that's the external non-rotation. Or you can say inversion and eversion, whichever you want to say, but it sort of everts your toes the other direction and outward. And it can actually have the subluxation is a actual dislocation, and you can have that more likely in the hand. And let's see here, you can have tendon rupture because of the deformities can put stress on the Achilles tendon and that's extremely. If you ever had somebody like kick you or not something run into the back of your heel and how awful that hurts. I mean, can you imagine rupturing and being, I guess a lot of athletes having something like that too. Okay, in the spine, it's usually limited to the cervical vertebrae. And this is the dangerous thing, though. If you have like a collapse of your cervical vertebrae, and there's damage enough that it can get to the spinal cord, what's going to happen from your neck down? I mean, yeah, the worst case scenario would be paralysis from your neck down. So that can be really, really dangerous. So if somebody has a sudden sharp pain in one of their arms or both arms, or loss of range of motion, you can notify, they need to notify their healthcare provider like immediately, because that phrenic nerve, and also that phrenic nerve that's in the cervical vertebra, in the cervical area of the neck, can keep the diaphragm from moving up and down, and you can just die. That's why some people die from the broken neck, if that phrenic nerve gets cut. Or damaged so much or too inflamed to be able to carry the message to the brain that you need to breathe, and your diaphragm's just going to be paralyzed. And then if you catch it and put somebody on a ventilator, that can work. But I think that's what happened with a lot of people with polio that just died suddenly. It's because that it affected the phrenic nerve, and then their diaphragm didn't work, and they didn't catch it and put them in an iron lung quick enough, and so they died from polio. My parents knew a family that happened to their daughter. And that was just, I really think about that. It was not that many years before I was born that happened. And so that was really a scary thing. You're like, somebody owes something that's okay. And here's usually affecting the joint symmetrically is what this is telling you about. And it shows you a normal joint and when it's affected. We sort of seen that before, but that's just another neat picture. This came from the Pharmacology book, actually, or one of the editions with that. And you can also have the high levels of circulating rheumatoid factor, and it does become a systemic disease instead of confined to the joints. And then we've got those immune complexes are what rheumatoid factor really is, when you can detect the presence of immune complexes. That is rheumatoid factor. That's what rheumatoid factor would be defined as. And it is a type 3 immune complex mediated hypersensitivity. So we don't think about it as that, but it certainly is. You don't think about a chronic disease being a hypersensitivity, but that's what it is. And there's another illustration, but you can kind of see how the fingers look sort of spindly even in that person on the left. But more than 10% of people with RA will develop deformities of hands within 2 years. And sometimes it can be workable somewhat, but when it gets to that deviation stuff and all twisted around almost like drawing a knot is what those other cases look like. And it's the function is very much decreased, of course. So, it's usually a lifelong treatment, including medications, physical therapy, exercise, education, and maybe surgery as a last resort. But it is really important to keep people moving, though. Even if it hurts to move, it's better to move because you're going to lose much more function if you don't, and especially lose muscle. Because the muscles are what helps the bones to do what they're supposed to do. And if your muscles aren't moving, you don't work your muscles, and your nerves are getting used to just not doing anything, then you're going to really lose function much more quickly if you don't at least not move some. They should be able to do real high-powered weight-bearing exercise, but you have to do some movement like walking. And what do you think might be the easiest exercise on the joints as far as sweat or water aerobics, exactly. So that's something to really keep in mind, that water exercise is probably going to be the very best for somebody with this, a child or an adult. So range of motion, individualized exercise programs, and that like we said, that you're not going to have the loss of joint quite as quickly as you exercise in some way. And you can use heat and cold treatments, whatever feels better or makes you more mobile. Sometimes splints and orthotic devices to help align the joints if they're becoming weaker, and you can't, your weight is low, then that's when you might need some of the assistive devices like that. And early aggressive treatment, and the earlier you can find it, but it's going to mimic other things. The fatigue is one of the first things that I bet everybody in this room is fatigued. I mean, you all have RA, but that's a lot of times. So think about that if somebody talks about fatigue, and then you see any joint problems too, to get that checked out. But anyway, the prolonged inflammation, of course, is what causes the joint damage. And the surgeries, you can sometimes correct some deformities somewhat and maybe cause a little more function. All right, and the juvenile, this was not in your book, but we need to integrate the pediatrics in whatever we do. So this is a page you really need to know because this is the differentiation between the children and the adults. So it can be very similar in treatment and all that, but they may have a remission that lasts for months, years, or their whole life. That they can't. Now that little girl that we were talking about, she's had it for 6 years and it's just getting worse. And so it looks like she's going to have a lifetime situation. She's not having remissions anymore, it looks like. But I know, I don't know if y'all knew Dr. David Agner. He's a rehabilitation doctor. Y'all know anything about that? Anyway, he used to work with the rehab patients at Rwanda. I'm not sure where he is right now. But anyway, his older sister had rheumatoid arthritis and was in a wheelchair for years, and she experienced a remission though, and she got married, had kids, and all this, and so she's, as far as I know, she hadn't recurred, and now she's even older than I am. So, but anyway, there are 3 types of it, and this pauci-articular and polyarticular, we just need to explain what this means. Because when you say like there's a paucity of something, what does that mean?
Not a lot.
It's just, yeah, not a lot, just a little bit. Paucity, that's a word we don't use a lot. I don't know why they have to use these crazy words to make it hard. But anyway, paucity, if you think of paucity, it means a little bit or not much. So that just means it's just in a few joints. Pauci-articular means it affects just a few joints. And that's the main thing to remember. It either affects a few joints or multiple joints, or it's totally systemic. And of course, the pauci-articular can develop into the systemic. So you have to consider it as a systemic disease, or at least potentially a systemic disease to begin with. But the person may have a total remission before it even gets to be systemic and juvenile. So, but the polyarticular means there's 5 or more joints. And all I care about really is that you know that it can be a few joints, many joints, or systemic. That's really the gist of it, okay? But just so you have the terminology, I have to tell you that. But few, many, or systemic. All right, and then that means it is for 17 years of age, and that you have these symptoms for at least 6 weeks with no other identifiable cause. And you don't have to remember that monophasic polycythemia persistent. That's part of the content and all, but just realize that it can occur for a limited time and then improve. It can recur periodically, and it can, if it's persistent, that means it's 3 to 6 months or longer in duration. So, but that you don't have to memorize that. Just know that there are different kinds of phases of it, and that it can vary from person to person. And complications can be the chronic uveitis in the eye, and that's the middle layer of the eye, and it also can interfere with normal growth and bone development, and there can be boys that have juvenile arthritis too, and boys tend to take longer to mature for a while. Robert grew like a foot here in college. It was just like, wow, how's the weather up there kind of thing all of a sudden. And so we, if it's at 17 and haven't finished growing, then yeah, that could be a big problem. Not just with boys, of course, but with anybody that's not matured in their bone growth yet. And then we can have the contractures or effusions as well. And then if you're using a lot of steroids, there's lots and lots of side effects from steroids, but in addition to all the other steroid effects that you know about, it also can stunt growth for kids. So, all right, when we're having an exacerbation, our first goal is to relieve pain. And we know that they're going to be more immobile when they have an exacerbation, but our priority to take care of the patient the best that we can is going to be relieving the pain. That's number one. And we do want to do give meds and put ice packs or heat or whatever to help reduce inflammation. Probably ice would feel better than exacerbation, it depends on the patient. And then we want to try to get them up and moving as quickly as they can. Because if they're just immobile for a real long time, then of course they're going to have less function ended up with, and then they may not ever get it back if we let them stay in bed too long. So, but we don't want to further damage the joints. We want to reduce the inflammation and so that they are able to move more and to keep their muscle function and nerve function intact and all. So we want to relieve the manifestations, of course, but the pain is going to be the main thing. Acute pain is going to be number one diagnosis. And then we use all our interdisciplinary team members to help us out with, like physical therapy and occupational therapy. And they're going to be fatigued even more than they were, at the onset, of course, when we got that exacerbation. So we certainly have to balance rest and activity, even if it is exercise and physical therapy and medications and all those kinds of things. We got to keep their life in balance as much as we can during that exacerbation, and have them to prioritize. So anytime somebody is suffering from fatigue from an illness, we need to have a prioritize, like anemia or something like that. You need to have them prioritize what exactly do you want to do the most, and then make a priority list. And then other things need to delegate to somebody else, or just let it not get done. And that's very frustrating to people that are used to being little go-getters and move all the time. So anyway, we can do some in the notes page. The anti-nuclear antibody, that means an antibody against nucleus of the cells. And so that's something we can measure. And the FANA just means a fluorescent version of that. It's a little more accurate. And there can be high sensitivity. CRP is more sensitive than the erythrocyte sedimentation rates. So sometimes you'll see different kinds of CRP values. And it does say that FANA is only positive in about 30% of RA patients. We use that test in lupus as well, because they're both inflammatory situations. Okay, and then we can examine the synovial fluid for inflammatory changes. So it gets cloudy, decreased viscosity, because it's supposed to be sort of, a lubricant and sort of oil the joint. It's just having lots of fluid in it that's doing its job. And then increased protein and white blood cell levels in the synovial fluid. And then, of course, you can x-ray the joints and see how damaged they are on the inside and how functional you can anticipate that they'll be. Now, sometimes you'll do CTs, especially like cervical spine and MRIs, cervical spine. You really do have to watch that. And when they draw out the synovial fluid, that procedure is called arthrocentesis. Y'all have heard about like thoracentesis and paracentesis. Like thoracentesis means you're drawing down in the pleural space, and maybe you've heard of amniocentesis with the amniotic fluid. So anytime you're in centesis, that means you're drawing fluid out of the accumulated fluid. Okay, and then the diagnostic criteria are listed. The morning stiffness lasting for an hour for 6 weeks or more, arthritis or the swelling or effusion of 3 or more joints for at least 6 weeks, arthritis of the wrist, the hand joints, the fingers for 6 weeks, symmetric arthritis, rheumatoid nodules, positive serum rheumatoid factor, characteristic radiologic changes of RA in the hands and wrists. So it has to be at least four of those particular manifestations to call it rheumatoid arthritis. Okay, and then pharmacology, aspirin and NSAIDs, because they are, what does an I stand for in NSAIDs? Right, so AI, anti-inflammatory, right? And you can use mild analgesics to reduce the inflammatory process, but Tylenol is probably not going to help with this because it's not anti-inflammatory, right? But now you can for osteo until it becomes inflammatory. Then low-dose oral corticosteroids to reduce the pain and inflammation, and hopefully every day, but some people do, and they make it as low a dose as possible to maintain the anti-inflammatory function there. And then there's DMARDs. It's they include gold, penicillin, antimalarial agents. And the first type drug that I really want you to be focusing on, I mean, I know I told you to look up some stuff in the pharmacology book, but the plaquenil is the biggie, the hydrochloroquine, that's the one I want you to look at. But I do want you to know about aspirin and stuff too, and I've got some other slides about that. But the plaquenil is really the one I want you to focus on. You don't have to know about all the gold and all that stuff. Just know that they use it. But the plaquenil does have some side effects you need to be aware of too, which is retinopathy and problems with blood cell production, especially white blood cells. Agranulocytosis means you're not making granulocytes. That can really increase your risk for infection. And people can actually die from that too. There are other drugs that can cause that side effect as well. You've probably seen that in the drug book when you've been looking at the medication in clinical. But another one that they use a lot for RA is methotrexate, which is a chemotherapy drug, but it does decrease the inflammation also, and so that's it's real cheap. It's generic now. It's been generic for a long time, so really it's not very expensive compared to some other things. And unfortunately, a lot of things hinge on how expensive the therapy is. I know y'all get tired. I'm going to try to go till 11 so we can do that other activity. If y'all need to go to the bathroom, you certainly can, but I'm going to try to go on and go through so that we can try to do everything you learn here. Yes?
My husband's on methotrexate, and they have up his folic acid. Does it do something with folic acid?
Yes, it is. That's actually what it does to kill cells, cancer cells. Is it inhibits the folic acid part of the cell division and the nucleic acids and all that kind of thing. And so you do have. I think it is. I can't always. I'm reading so many sources when I'm preparing everything, but I know in one of your sources it does say that when you use methotrexate, that most of the time people have to have folic acid supplements because it can inhibit making your normal DNA and reproducing your normal cells. So, and it can cause sore mouth and that sort of thing as well, because it kind of kills some of the cells in the mouth. And with the chemo, the doses are going to be a lot higher than it is for inflammatory conditions. But they also give methotrexate sometimes for the ectopic pregnancies, because it helps to prevent the cell division rather than having to go in and do surgery on taking it out. So it just kind of shrinks down and stops the cell division. So anyway, that's kind of a thing to think about. But that's one thing that they can do to prevent having to have surgery. Okay. Did that get your question, Holly? Are you good?
Yes, ma'am.
Okay.
Thank you.
All right. Okay, so, okay, I think I got that one covered. All right, aspirin. Aspirin's really cheap too, isn't it? So that's really a good thing. What are some other side effects from aspirin besides the platelet inhibition? We know about the
Upset
platelet
stomach.
inhibition. I think everybody's probably had that in close. What's that?
Upset stomach.
Yeah, it can irritate your stomach. Because what's it made out of? And ASA is the abbreviation. Acetylsalicylic acid. You already got a bunch of acid in your stomach, and then you're putting more acid in your stomach, and your stomach's pretty strong most of the time, but sometimes aspirin can burn a hole in it if you've got other situations going on, and maybe your nut is intact, or whatever. And then if these high doses that you usually take, if you see that dosage 3 or 4 325 milligram tablets, now how much would you usually take for a headache for aspirin dose for an adult? Like 2, yeah. So 3 to 4 times a day. I mean, can you imagine how much that might eat your stomach? Oh my gosh. And decrease your platelet function too. So you got to watch for bleeding and bruising and all those kind of things. And also in those high doses, anybody know what tinnitus is?
Ringing in the ears.
And it can eventually cause hearing loss as well. And that's mainly salicylates, not all NSAIDs, but salicylates, which is aspirin, and indocin is another one. Indomethacin is what it's called. You don't see that very often, but sometimes. And let's see, if aspirin's not effective or it's not tolerable, you can use some other ones like Celebrex or ibuprofen or naproxen. Indocin is probably going to have about the same side effects. But all of these that are anti-inflammatory inhibit which inflammatory mediator? Synthesis, what is it? Prostaglandins. Yeah, prostaglandins is what makes women have menstrual cramps. That's a prostaglandin. So that's why the term is its best friend when you have a period and you got cramps. And okay, and so you have to kind of see what works for each patient and what they can afford or what their insurance will pay for. Unfortunately, that's a big piece of it. So cost is definitely a factor. And in any of the NSAIDs, it's a good idea to take with meals, milk, or antacids, or use enteric-coated. Now, I read somewhere recently that enteric-coated, especially if you're taking it for heart, for the platelet inhibition or whatever, to try to have the heart function, cardiovascular function, that it may not have as much activity in increasing the cardiovascular function if it's enteric-coated. So I don't know if that's true or not, but that's I have read the word that they kind of investigating that to make sure that it really is as effective or not. And it certainly, and when somebody has symptoms of a heart attack, what do they tell them to do first? Just take an aspirin, but it can't be an enteric-coated because it's not going to get to you quick. So if you've got somebody having heart attack symptoms, don't give them an enteric-coated, because that's not going to dissolve as quickly. And let's see, the NSAIDs can be toxic to the kidneys. Not so much the aspirin, but the ibuprofen and the naproxen and Celebrex, they can certainly be. And they can have some cardiovascular effects as well. So you think if they inhibit platelet function somewhat, that would be helpful for your heart. But sometimes that's not the case. So, all right, corticosteroids can dramatically relieve the symptoms. And you know how that does with COPD exacerbation. You usually see IV steroids, don't you? Like Solumedrol or something like that, or hydrocortisone or Decadron. But mainly we've been seeing Solumedrol in our patients, and then we have to give it IV, and then they gradually get them onto a taper of an oral form of the steroids, and then hopefully can wean them off of it, or at least wean them down to a smaller dose is what we still do to decrease the possibility of inflammation flaring up again. So anyway, but of course long-term use, we can have the multiple side effects like the diabetes. One of the symptoms that we haven't really talked about with the corticosteroids is that it can cause insomnia if you take it at bedtime. And it can really it kind of makes people hyper. I know when we would give steroids with certain chemotherapy drugs, and sometimes it was part of the regimen. Actually, steroids can be part of chemotherapy regimens because they do change the environment of the cell as a hormone. It just changes the cellular environment to where it can be like a static. It can make the cell division static. It doesn't kill the cells, but it inhibits the cell division of some kinds of cells, especially like plasma cells, like in multiple myeloma and in lymphoma and in Hodgkin's disease that have to do with the blood and lymphatics and leukemias. They have corticosteroids as well. And so you find out with those people, they have to take these huge doses, and sometimes they'll divide them up, but if you do divide them up, the patient's not going to sleep. And when they are on the corticosteroids, it's usually in spurts of high doses of it, and they'll just feel so good at first, and they'll just clean their house, or if they're able to, if they're going to the hospital and all, they're taking it orally, they'll just be taking on the drapes and vacuum everything and all this stuff, and then a few days later, when it wears off, the effect wears off, they feel like they've been hit by a truck and they have no energy whatsoever, and that's like the Addison's disease thing, when you don't have enough, you don't produce enough corticosteroids. Cushing's disease is when you produce your own cortisol in your adrenal gland, but it's too much. But if it's too little, that's an adrenal gland kind of thing, and that's Addison's disease. You may want to write that down because they were just talking about these tablets and everything that the students were not knowing about Addison's disease, and that's not one of y'all's exemplars. I think it is in your metabolism unit, for the reading, but that we didn't want to sign all of that. Addison's means you've got too little cortisol production, so that can make them have electrolyte problems and that sort of thing. Really either way too much or too little. Anyway, we can have the poor wound healing, increased risk of infection. Our bones can get softer with chronic use of the steroids, and then the GI bleeding can be with long-term use as well. And it can be a risk even with short-term, but especially it gets more so with long-term. And we want to try to do low doses daily, wean off the medicine over days to weeks after an exacerbation is what they're talking about, but never stop abruptly after they've had it for a long term, because then you can have an Addison's disease kind of symptom, put your electrolytes on with renal insufficiency. And so that means sluggishness, fatigue, weakness, no electrolyte imbalance. So I think I put that on there. That was what I added into that particular slide. Now I did put that on there. Okay, and then we've got the DMARDs. And so that they're all aimed at modifying the immune system and the inflammatory responses, and that's sort of a delayed thing. But that's the gold salts, anti-malarial agents, hydroxychloroquine is one of that's actually what Plaquenil is. It is a malaria, anti-malarial, and then the sulfasalazine. You just may see a lot of those. And I always it's on the slide here, Polly. It does say folic acid to control the side effects of the methotrexate if you're taking with the NSAIDs. And I knew I had it from somewhere. And that can help prevent the gastric irritation and the sore mouth and the blood cell issues that you can have too. They can decrease the blood cell count too. Then you actually get the chemotherapy. You don't take the folic acid. It's contraindicated because you want the folic acid to be inhibited because you want the cell division to be stopped, and you want those bad cells to die. So, but in this case, we don't want them to die. We just want to do the anti-inflammatory, keep the anti-inflammatory portion of the supplement of folic acid, so you don't have the other problems.
Yeah, he's got psoriatic arthritis and celiac disease.
And that psoriatic arthritis is listed in the book, isn't it? And I didn't really assign that for y'all to be responsible for, but that's very similar treatment and everything too then, isn't it?
It is.
Okay, psoriatic arthritis, that sounds awful, and it is, I guess, isn't it? Yeah. And then cyclosporin is an anti-inflammatory drug that you might give for organ rejection. And I just wanted to put that in there. That's what's in those basic eye drops. But people with chronic dry eye, that could be like the Sjogren's syndrome people have. And it's an inflammatory thing for people that have an autoimmune disease that's causing the dry eye. That's what it's really for. But it is an alkylating agent no, maybe not that one. It's not that one. The Imuran is an alkylating agent. And just realize that Imuran is a real common one that can be used as an anti-inflammatory. And sometimes people will have cyclophosphamide as well. And you know, we had studied that somewhere with the cancer unit. And it can cause blood count, white blood counts, and that sort of thing too. And so you got to be real careful. If somebody has a decreased white blood count, what do you got to be careful about? Imuran and cyclophosphamide, there is risk for infection. And you can with methotrexate too. It doesn't really say that. It's not an alkylating agent. It's a folic acid inhibitor, but that still, all of that can inhibit some normal cell blood cell production. So risk for infection because of the medications can be a big deal. And then Arava and Enbrel are injectable, and Remicade is a monoclonal antibody, and Humira is a Q injection. You should hear some of those advertised on TV now. Those are biologic response modifiers or monoclonal antibody inhibitors. Those are biological agents, targeted therapies is what those are. And what they do is they seem to be immune response. And let's see. then I've got another thing about Plaquenil down there. Usually people have not responded well to other anti-inflammatory drugs like the aspirin and everything. And that it can cause retinal changes with prolonged or high dosage use, and it can be irreversible in some patients. And especially if children have to take it, because they're real tender in all those areas that are not totally matured, and their retinal changes might be permanent. They could possibly become blind, and adults could too, but children are very vulnerable to that, and sometimes we have to use it. And all these other ones, you can just read more for the information. I do want you to think about the traxate, cyclophosphamide, and but mainly with Imuran and cyclophosphamide increases the risk of infection and traxate as well. Okay, and then the surgical procedures on the next slide. There we go. Synovectomy means we're taking the synovium out because it's inflamed and it's not producing the fluid like we think. Arthritis, when you do the desis, that's kind of like a fusion. So, the desis is being associated with arthroplasty. Plasty sounds like plastic surgery, like you're creating something new, or plastic surgery sort of, but you're creating an artificial joint or restoring it to its integrity and functionality. And you can also have plasmapheresis, which it takes the blood through a filter and it filters out those immune complexes. I think we talked about that a little bit yesterday. And then the total lymphoid irradiation is very drastic, and that induces a strong immunosuppressive effect, but it certainly can have a lot of side effects too. So you hopefully wouldn't have to have that, but if that's necessary, you might do it. So, and they usually do that synovectomy in the knee or the elbow because that's a bending influence. And then the arthrodesis is a stability thing, mainly in the cervical vertebrae. So we see that. Arthroplasty is just to try to get a little more functionality, like in the hands and all that. I guess it could be other joints as well. But the hands are where you really see the tremendous deformity. And then the plasmapheresis with removing the circulating antibodies, and you have to do it repeatedly. It's not going to just go away after one time. Your body's still producing those antibody complexes. And then the total lymphocyte counts decrease when you do that total lymphoid irradiation, where all the lymph nodes are and lymphatic organs are, but the serious side effects like infection. Okay, rest and exercise, balance program, we've already said that. And heat and cold, all that, I think this is just a reinforcement here. But don't stop being active altogether. I've got that on the slide now. Splinting inflamed joints can provide some local joint rest without having to totally give up your mobility, but it will rest the joint and prevent damage when there's a lot of inflammation going on. And then PT and OT can help you become more functional or continue to be functional, and reduce strain on the joint with the orthotic devices. All this is repetitive, but nutrition, you want to do an anti-inflammatory diet, like mostly vegetarian, and using olive oil or fish oil, or eating the fatty fish that have the oil. And especially like, I know sardines is one of those, but any kind of fish can be helpful, but using an anti-inflammatory diet. And fish oils, you can even use fish oil supplements, but it is omega-3 fatty acids that we're talking about. And then you want to have enough of your calorie intake to be able to be active. And people that are obese and have RA have a problem because they've got more weight on those joints, and the knees are really in trouble if you are overweight and you've got RA. So I've seen some people that have had RA and really tried to lose weight because they're on prednisone and all this stuff. Prednisone can cause weight gain. I don't know if we really talked about that either. It can cause fluid weight gain. but it also can cause fluid retention, but it also can cause you to be hungrier. And so you eat more too. And so how can you lose weight when you got RA and you're taking something that makes you hungry and makes you fluid and all that kind of thing? So people have the bariatric surgery to be able to lose weight to protect their knees and their joints and all that. So, and then some people are vulnerable to quacks that will do, they're getting all kinds of things and still try to sell you things and guarantee a cure, and that's not possible. So they're trying to talk people out of it if they're doing something crazy. I'll let y'all look over your nursing diagnoses because I think it will make sense to you what those diagnoses are. And this lupus one is really, really shorter because of and you can follow up with the follow-up activity. Don't take your tape off for most of the pro have, but was it pretty aggravating? Somebody had to do like that all the time. Okay. This is very, very, very similar. There's just a few differences. But lupus is a connective tissue disease, and it's a systemic kind of thing. Also, it can affect organs, and the manifestations can be real variable from person to person, but it's the antigen antibody complexes too. It's the same cause as far as what the immune system is doing. We don't know why people get it, but we know that they have those immune complexes, and that's what's causing the inflammation. And it actually is more likely to have the nucleic acids being attacked, so that anti-nuclear antibody test is more often positive lupus than it is for RA. It can be an RA, and then you may have lupus and it might not be positive. Some of this is very vague. It's hard to diagnose sometimes, but that's anti-nuclear antibody is the ANA. And you can, again, just like with RA, you can have remissions and exacerbations or flare-ups. And did I have another connection to a? Okay. I may just let y'all watch that on your own. It's just a little news show about a patient with lupus and about their primary care person taking care of them. But y'all can follow that link because I tested it the other day and watched it. But y'all can watch that one on your own and just sort of reinforce it. It just has another person, gives a face to it, and I think it helps to kind of see a face when you're thinking about these diseases. So I'll get you moved on here. Okay, so, and this is still a self versus non-self thing. You don't have to remember all that whole definition thing, but it is autoantibodies, so it is B cells. We have antibodies against our old cells, and that's the issue here. So, the immune complex is deposited in joints or other body parts, organs, even to trigger inflammatory response, and then you have the tissue thing. And what we need to watch, the biggest priority in most lupus patients when you're assessing them is to watch for their kidney function, because it seems that those deposits want to go to the kidneys in a lot of cases. It doesn't for everybody, but you know that it's possible that it can, and so kidney function is so critical to our life processes. We just need to assess them for their renal function, and we need to teach the patients to watch their kidney output and everything. If they have a change in output or any kind of problems with their urinary function, even if they had an infection, if they got the pyelonephritis or something like that, that could damage their kidneys too. So if they have a urinary tract infection, you want to get right on it to not let it get to pyelonephritis. So teach the patients about assessing their urinary function. If they got any dysuria or anything, get right on it and shoot it and treat it, and don't let it cause damage in that other way. If you've already got pre-existing damage and then you got lupus, that's just double trouble, or maybe more than double. It can be in any body system: musculoskeletal, brain, heart, spleen, lung, GI tract, skin, peritoneum, everything. It could be anywhere. So we don't really know, but genetic, environmental, hormonal factors like with RA, we don't really know that. And some viruses and bacteria, chemicals, drugs. Ultraviolet light is one thing that you don't see as a potential cause for RA, so that's one of the things that's different too. So remember that lupus and light are are not real compatible. So the light can aggravate it once you already have it too. And it might be, it could be part of the cause. And then there's something hormonal with women. Women are more likely, it says, it depends on where you look. It says 9 times more likely than men to have lupus. And it does have something to do with androgen levels. And androgens that can, because women have androgens too, we have testosterone too, we just don't have as much as men do. But if they don't have those particular androgens that can inhibit the antibody response, then they're maybe more likely. That's just a theory, that they think that the hormone has something to do with it. It's usually women of childbearing age, and then in childbearing age is 30 times more likely than men, but over the lifespan it's like 9 times. It's more common in African Americans and Hispanics and Asians than it is in Caucasians. And sometimes there can be drug-induced lupus symptoms, and if you take the offending drug away, then everything will go away if it's just a drug side effect, unless it's gone too far to you've already got organ damage or something and you haven't paid attention to what it might be. But procainamide, hydralazine, and isoniazid. Isoniazid is a TB drug that we talked about, pretty similar as well. But hydralazine is what? Anybody know hydralazine? It's a blood pressure drug. So, yeah. So, I think that's an entirely and then the biologic response modifiers, or the targeted therapy, biologic therapies for RA sometimes can cause lupus-like syndrome as well. So you don't have to give them a different kind of medication if it does. Okay, and we do have the classification. It can be systemic, or the drug-induced is just what we said in the previous slide here. The drug-induced, we can get rid of that totally. The discoid is only on the skin, and if you get sub-exposure on those discoid lesions, you have a good picture in your book, so I didn't put it on. Well, I think it's in one of the slides too. But if you have a lot of sun exposure, then that can decrease, or that can increase the flare-up of the discoid. It can make it worse. And it's one of those things where body image is really important. It's like if a teenager has that and they've got these marks all over them, and then they go out in the sun, they go to the beach and get out in the sun, and even get worse, and then they can't be seen out in public. They really, especially, well, anybody doesn't want to look like that. So, but that's a big deal. It is limited to the skin. That is not a systemic disease, and it is not got the discoid type is not going to go to the kidneys. So, but it can cause scarring. And works with UV light or sunlight, any UV light, so you want to can and then as well. Then the systemic can involve any of those cardiovascular, central nervous, kidneys, lungs, musculoskeletal, any other one, and it might be multiple. So any of them are involved in considered systemic. Okay. Painful swollen joints, fever, extreme fatigue. You've heard this before with RA, haven't you? The difference too, another difference is the red rash, especially on the face. And why do we call it lupus? Anybody know what lupus means in Latin? Woof, right. So it's just people thought it looked like that butterfly-looking rash. They look like a wolf's nose. And so that's why we call it lupus. And for leukomatosis, erythema means what? Red. It's a red wolf face, I guess, is kind of what that's trying to say. You can have alopecia, which is hair. Yep. You can have the pale cyanotic fingers or toes, like the Raynaud's syndrome, sensitivity to the sun, and a rash developing to exposed skin, even in the systemic, but with the discoid especially. And edema around the legs and around the eyes, ulcers in the mouth and large glands. I mean, this is all over the place, and that you can't really memorize all that. Just almost anything could be a lupus sign, depending on what body system that it's in. So when you get into valve remission and exacerbation, if they are in active disease, there is an increased risk of infection, but the medications that you take can increase the risk of infection as well. So you might have, mimic the RA. You can have weight loss, joint problems, all of that thing, the polyarthritis. The only thing is, it's not often a deforming kind of arthritis. It does not deform the joints most of the time. It can, but most of the time it doesn't cause joint deformity. It can cause inflammation of it and pain, but it doesn't usually cause a deformity of the RA. So that's another difference there. And then there's a possibility because the nervous system can be affected, like with seizures or depression or strokes. And this is this is the neat picture, and it probably look better on your computer. But there's the rash, the lupus rash, and then here's some body systems that can be affected. And that's rash again in a drawing. This looks like more of a photograph. That's a Raynaud's syndrome where the blood just kind of goes out of the fingers. It goes white due to the inadequate blood flow, and then it turns blue as oxygen's depleted in the tissues. But then it comes back, and there's our discoid, and you can see how ugly that is on that. I guess that's an arm. It looks like an arm. So that's a bad thing. Okay. Okay. 50% of lupus patients have renal manifestations, and up to 10% will develop renal failure and can end up having to have dialysis or transplant. You can have the anemia of chronic disease again, but you can have white blood cells and the platelets increased as well. And then the GI and all that, you can read about that. The other thing to remember is that women that conceive when they have active disease, if they get pregnant when they're in active disease, not in a remission, they can have an increased incidence of spontaneous abortion or miscarriage or stillbirth or prematurity or growth retardation of the fetus. And then they can have congenital heart block. It can have a lot of fetal problems anyway. You have to remember what they are, but remember that it can cause problems for the fetus or abortion of the fetus, spontaneous abortion. So, but the prognosis can vary, but any heart damage that they get is for the uterine. The father of the uterus is a permanent heart problem. And the other weird thing, though, is if a woman conceives while she's in remission, there's usually not any problem for the fetus. So it's just that it's a real tug of war of how do you know if you're going to be in remission if you're trying to get pregnant. You might be just right on the verge of a flare tomorrow and then you get pregnant. It's really, that's a tough thing. They need a lot of counseling. And the 10-year survival rate's 70%. So it is something that you have to work with for a long time. Pharmacology, and this is really about the same thing. We've got our NSAIDs, our plaquenil, our corticosteroids, in the low-fat, mostly vegetarian diet with the skin symptoms, and know about the plaquenil again. That's the same thing. And then our cyclophosphamide, azathioprine is the Imuran, and those are the ones that can cause risk for infection. And then I don't know that they use methotrexate with lupus. I haven't heard that. Y'all, I know that was not in the information anyway. But the cyclophosphamide and the Imuran, the plaquenil certainly, and they need to avoid sun exposure. That's what you need to definitely teach your patients with lupus. And if they are in a remission, they could experience a flare-up if they are out in the sun. If they have to be out in the sun, they need to use at least a number 15 sunscreen when they're outdoors. And if there's skin lesions like the discoid, they can use topical steroids. Another thing to remember about lupus that is different again is that estrogens, birth control pills, can trigger an acute episode or exacerbation of the lupus. And then a pregnancy can trigger the exacerbation also. But again, if they conceive during a remission, that's not going to exacerbate these symptoms. It's not going to cause them to exacerbation. So it's really, really timed. And then, I can tell you, maybe some young, when you think you want to get pregnant, you just want to, think you're just going to try for a couple months and boom, it's going to happen. That's not the way it always works. So even if some have chronic diseases, so it's going to be really difficult for people that have a chronic disease like this to plan a pregnancy and have a good outcome. And then dialysis and kidney transplant can be like a worst case scenario as well if it progresses to the end stage. And you do want to try to give them stress relief advice, like the guided imagery and yoga and massage and aromatherapy. And another thing that was not in your information that I noticed was that that people with lupus shouldn't use hair dyes or frost, to have their hair frosted or do perms, have the kind of treatments to their hair, because it scalp stimulates their skin too, unless they're in a period of remission. If they're in remission, they can do that, but it's not a good idea to use those things. I'm sorry, okay. Chronic pain, disturbed body image, all those things, and there's lots of risk scores, of course, too. A lot of psychosocial. So I think most of the things that are on this notice page are pretty self-explanatory too. They will make sense to you. If you have any questions about any of that, you can let me know. But I think it's neat that the other book at least did give us a nursing process and kind of guide us along. It's going to be individual for each patient.